So the long-term plan in 2019 was published, and in this long-term plan, which is kind of a call to arms for our NHS, there are 2 sections which describe familial hypercholesterolemia. And these highlight the number of patients in the UK, in England, that are affected by FH, and they also highlight the fact that we don't know, most of the people who are affected by FH don't know that they're affected by FH. And in 2019, there was a pretty ambitious plan set that we would reach a number of 25% of those patients having that diagnosis, but within 5 years, within the next 5 years, through the genomics program. So the impact of familial hypercholesterolemia is really great. It's a really common disorder, so 1 in 250 of us will have a genetic variant that causes us to have a dysregulation of our lipids within our bodies, and that causes us to have an increased lipid level, early onset of coronary artery disease, and that can cause heart attacks and people to die. So the numbers are really quite stark, and by the age of 50, in men, 50% of these patients will have coronary artery disease. And half of those patients will die of an MI event, of a heart attack. In women, the numbers are a little bit better. So by the age of 60, 30% of those individuals with familial hypercholesterolemia will have coronary artery disease. And the same again, about half of those will die from a heart attack. Thank goodness we've got some great treatments. We've got statins, we all know about statins, and we've got dietary treatments for FH. And if you treat patients early with these treatments, then you really reduce the rate of coronary artery disease and that risk of having a premature death in these patients. So if you go to the doctors and have a cholesterol test, then the doctor knows that you've got a high level of cholesterol. They can start to treat you immediately, give you some advice on smoking, drinking, and your diet. And actually, doing a genetic test doesn't really mean much for you as an individual person. But by identifying the genetic variant in that patient, you can start to do cascade testing in their family members to identify more individuals. So familial hypercholesterolemia is a dominant disorder. If you're a patient, then you've got a 50% chance of passing that on to your offspring. And so within a family unit, 50% of the individuals within that family unit will have hypercholesterolemia zone. So a few of us have got together and really tried to generate a set of web pages and documents that provide all healthcare professionals with the opportunity to become confident and competent at ordering genetic testing for familial hypercholesterolemia. If we're going to get to that 25% and move forward and get to 100%, then we need everybody who can to be thinking about ordering genetic testing. So what we've produced is 3 documents and these 2 web pages, and they're published now on our website. The FH pathway is a flow chart, a clinical pathway that hopefully people can print out, stick on their wall, or go to as a reference when they see a patient with a high cholesterol level and they're thinking, well, perhaps this could be familial hypercholesterolemia. We consulted widely on that FH pathway, and that came up with a lot of questions. And so we've put a lot of the answers and those questions, a lot of the questions and those answers to those questions in a frequently asked question document. And then we've also tried to simplify the test ordering process for FH. Now, this is still a piece of paper form, but you can edit it on a computer. And the point in this form is to provide an easy way that a healthcare professional can select between ordering a diagnostic test or a cascade test for FH. We've also aware that the consent discussion around doing an FH test in a patient is very different from doing a whole genome sequence. And so what we've done is we tried to distill the important implications for that patient and that family in 4 sentences, and we've added those sentences to this test order form. So actually, that clinician, that healthcare professional who's ordering that test can use that whole test order form to order that test, but also have to use those sentences as a guide to have that consent conversation with the patient. The second project that I want to talk about is the largest project that we've been doing, and this has been a joint effort from the GMSA, the GLH, an academic group in Nottingham, and a company called Eclipse that live in Norwich. So the academic group in Nottingham published several years ago a logarithm that helps to identify patients that have a high likelihood of having FH. And they're using lipid data and a bit of family history data and a bit of phenotype data to do that. So you can do that within, a computer system and pull out numbers of people who have high risk and low risk, but that's not much use to us as delivering healthcare. The Eclipse database, database is a GP record database. So GPs use, one of probably 4 or 5 IT systems across the country, and so it's very easy to pull data out of those GP records, and we can use, if you combine these records with that logarithm, then you can start to stratify patients within this tool that we've generated to identify those individuals that have a high risk of having, a high likelihood of having FH. So we've got this tool, we're calling it the FAMCAT Eclipse FH Hub tool. Maybe we need a fancier name for it. So this tool can provide a list of patients, and this is still anonymized. And then we have a system within the Eclipse data system as well, where patients can be contacted directly. So this is still anonymous. Nobody's phoning them up and saying, we think you've got FH, do you want an appointment? They would receive an email or a text to say, would you like to log on to this website and find out more information? And so the patient would log onto the website, provide some information about their family history, perhaps a lipid profile, and they would consent for contact. And the patient engagement team would then phone that patient and arrange an appointment with our FH Hub. So the FH Hub is a virtual entity, which currently is a lady called Shalina, a specialist nurse called Shalina, and our FH Hub is in Norfolk and Norwich, and it's serving the population of Norfolk and Waveney and some GP practices within that population. So our specialist nurse would have a conversation with that patient. They would go through the results of that questionnaire, and they would arrange genetic testing, talk about treatments, feedback information about diet, and hopefully once genetic results are come back, then they would start to arrange cascade testing for family members. So we've gone from an academic logarithm, a system that allows you to interrogate GP records, to being able to use that information to stratify patients, contact them, and have those conversations around genetic testing with them. So we've got one pilot site at the moment, as I said. We've got one wonderful specialist nurse called Shalina. But I think that this is a model that we've tried to, this is a pilot project that we've set up because we think that this is the model of how we're going to deliver FH testing in the future. So the final project is on a very different scale. It's a very small project in the Cambridge lab, and one of our trainees is doing this project. One of the barriers to genomic testing is around the phlebotomy clinic. So a patient has their appointment and they would like to have genetic testing, but they still have to go to a phlebotomy clinic and have blood drawn for that sample to then be sent to the lab and be processed. So at the moment, we're hearing very different things about phlebotomy clinics in our region, but it's a resource that's precious, and we know that people are waiting quite a long time sometimes for their phlebotomy appointment. So just to quickly tell you that, so once the sample would come to the lab, we'd sequence it, and then we'd analyse that data and report that. And what our trainee is doing is trying to see whether or not we can use DNA extracted from saliva samples to do that diagnostic testing. So this is something that's, we do use DNA extracted from saliva in the NHS for genetic testing, but we haven't yet in Cambridge used the saliva DNA for diagnostic testing using our next generation sequencing panel. So this is a project that's ongoing. I hope in a few months, if this is successful and we're all crossing our fingers, then we can start to introduce home sampling to this pathway to then, mean that we're not having to use those precious phlebotomy services when we can do home sampling. And hopefully it will be a much more equitable way for patients to contact their family members for cascade testing by just sending a pack with a saliva sampling kit to them. So I guess just to finish, before lunch, I think I've told you about 3 projects. One around how we're providing information for mainstreaming genomic testing for FH. The second around case finding, which is our transformation GMSA project. And the third around a small project that we're doing around sampling, which is hopefully going to impact significantly on that pathway and how we can get samples from a patient to the lab. So back to that NHS long-term plan, I think we're nearly getting towards our 25%, but I definitely want to tell you that we're not going to stop there. We're definitely going to work towards that 100% moving forward. And we will do that by identifying those key patients and then doing that cascade testing on those family members. So there's lots of people to thank, especially our FH specialist nurse in Norfolk and Norwich, Shalina, and my trainee in Cambridge that's also called Kate. Thank you.